There is an entire set of ACC/AHA guidelines on perioperative cardiovascular evaluation and management of patients undergoing non-cardiac surgery. It's an important topic, and that's because MACE after non-cardiac surgery is often associated with prior CAD events. So in the December 20th, 2016 issue of JACC, there's a paper on the risk associated with surgery within 12 months after coronary drug-eluting stent implantation, and the accompanying editorial comment is entitled, "Surgery After DES Implantation, to Operate or Not to Operate, and Is It Still a Question?" So to answer this, I'm with Dr. Christian Spaulding, who wrote the EC. He is an MD, a Professor of Cardiology and interventional cardiologist at the European Hospital Georges Pompidou, Paris, Descartes University in France. Now, let's start off, please, by talking about what you call one of the most challenging decisions in the contemporary cardiology era, and that's giving the green light for non-cardiac surgery after a patient has been in recently for a drug-eluting stent implanted by PCI.
Well, it is a clinical problem.
A common one.
And a pretty common one. It occurs in approximately 5 to 15% of cases after PCI when we get a phone call from a surgeon asking us, what in the world am I going to do with this patient? I have to do surgery. You just did PCI on this patient. He is taking clopidogrel and aspirin, so this is going to increase my bleeding complications or even contraindicate the surgery. What should I do?
Right.
And it's a very complicated decision that has to be taken by a team with the cardiologist, an anesthesiologist, and a surgeon. And for the moment, it is a gray zone. We do have guidelines, but let's face it, they are mainly based on expert decisions and on non-randomized trials.
So let's talk about the main paper by Egholm et al. And their contribution to the field. What do they do and what do they find?
Well, first they use the Danish registries, which is an absolutely fantastic database. They have data on all of their patients that are treated in Denmark. They looked at patients who had surgery and focused on patients who had had PCI in the year before surgery to be able to determine the rate of adverse events. And what they found is that patients who had previous PCI had a higher rate of adverse events 1 month after PCI and no higher rate of events if you pass this 1 month. In other words, the danger zone is 30 days after PCI.
Which is pretty good news to know. Was it surprising? I mean, obviously there's going to be a window of risk, but was it surprising that it was as small as 30 days?
Well, yes and no, because we do have some registry data coming, for example, from the Paris registry, which was published in the Lancet, showing pretty clearly that they had the same window of 30 days. And what's also very important is that when the physician is the one who takes the decision to stop dual antiplatelet therapy, for example, for surgery, for a certain period of time, the risk is low. If the patient stops DAPT during the 30 months, the risk is very high.
So what does this study add to the difficult decision-making process then for non-cardiac surgery?
Well, I think it's very, very important data that's going to help us in our everyday decisions. Basically, I think that if a patient can wait for surgery, it's better to follow, obviously, the guidelines and wait for 3 months or even 6 months if you can wait. If the patient can't wait, for example, if there is bleeding that you can't control, pain that you can't control, cancer that has to be treated rapidly, this manuscript does give evidence showing that you can stop clopidogrel after 1 month. However, we do need randomized trials on that topic, and currently there are several randomized trials that are either ongoing or going to be started to be able to give definite answers to that very difficult question.
I mean, I liked one of the comments that you had in your editorial. This study is bright testimony to the value of the large national data registries, which bring answers to questions that cannot, as of now at least, been solved by randomized trials. But they are underway, and hopefully we'll get some more answers. For those patients within that 30-day window, what's the safest way to handle them? Any advice?
That's a difficult question. Try to wait for 30 days. And if you can convince the surgeon to operate the patient with aspirin and clopidogrel, on board, have him operate, but be close beside the patient, the surgeon. And if you really have to stop it, well, in that case, the operation should be performed in a center that has interventional cardiology with an interventional cardiologist that is ready and on board during the operative period.
It's time for somebody with a lot of experience in handling these high-risk patients.
That's right.
So this paper and the accompanying editorial comment is in the December 20th issue of JACC. Please look for that. For CardioSource World News and CardioSource World News Interventions, I'm Executive Editor Rick McGuire.